Thank you so much. My name is Monnie Wasse, and I'm an interventional nephrologist at Rush University Medical Center in Chicago. And I'm really thrilled to, not thrilled to follow Prabir, but there's nobody who actually lays out really an inspiring vision around vascular access better than he does. So thank you. We'll cue my slides here. All right. So I'm sorry I'm not able to see these on my screen, so I'll look off to the right here because they're not popping up. I was asked by the organizers to speak about new technologies in vascular access creation and maintenance. This is less of an inspiring visionary talk and more of a practical talk about what is out there and available currently and is being worked on its way to FDA approval. And then we'll be hearing from our surgical colleague following my talk who will round this whole thing out. Here are my disclosures. So just briefly, the outline for this talk is around what new devices and technologies exist for vascular access. And I'll just briefly cover some aspects around prevention of dysfunction, detection of stenosis, and then treatment of dysfunction. So I like this outline that was laid out by one of my colleagues, Dr. Wasse, who wrote a paper recently that was published last year on new devices and technologies. And the bits that I'll be touching upon today are those that are in red. They're around central vein occlusion, and then many of you have heard who are in the nephrology space of endovascular AV fistula creation, so I'll touch upon that. And then what is new with drug-coated balloons. Some of those that I've left out are ones that don't have as much new technology, and this is an innovations talk. I wanted to touch upon those things that were most pressing and exciting in the field. So if we start off with preventing access dysfunction, I want to just talk about the two FDA-approved devices that are on the market for endovascular technology in creation of fistulas. And this is really, these devices were created with the intent of making an endovascular ability as opposed to a surgical ability to create a fistula. And they're brand new, and the technology is new and groundbreaking in the sense that for the last 50 years, fistulas have been created surgically, and finally now there's a way by which those of us who do endovascular work can take these devices in our hands and utilize these in a much more fast, rapid way without having to go through many times the onerous clearance that some of the surgeons have to face, and so we can carry these out in our own offices. Two that are FDA approved. One is called the Wavelink, which is a dual catheter device using an RF electrode, and it's placed under fluoroscopy, so you need radiation to be able to administer this. And then there's the Ellipsis ultrasound-guided device, which is a single catheter electrocautery device that's placed under ultrasound. And you'll note from my disclosures that I'm actually the national PI for their post-market trial, so I'll be touching upon that a little bit more simply because I'm more familiar with it because I use it myself. So what the devices have in common is that they are designed around the vascular anatomy in the proximal forearm, so just below the antecubital crease. And a prerequisite to them is preoperatively assessing the upper extremity vasculature using ultrasound to determine suitability. There are diametric qualifications for both of these. But the goal is to create an AV fistula between the proximal radial artery or the ulnar arteries and the deep adjacent vein, with drainage via the perforator vein to the upper arm superficial veins. So for those of you who aren't as familiar with this anatomy, let me briefly go through it. What are the perforator veins? Just briefly, the perforator veins effectively serve as a bridge from the deep veins in the forearm to the superficial veins in the upper arm, because that's what we want to actually be able to cannulate in our patients. So it relies on there being sufficient flow and opening of that bridge to allow for flow to go to the upper extremity vessels that you can stick, and the nurses can actually and techs can sufficiently cannulate. So how does this differ from a surgical fistula? Well, most people postulate that this preserves the vasa vasorum. We don't handle the vessels because we're in the vessel itself, and so there's no cutting and touching it and any perturbation that's associated with the vasa vasora. And in many cases, what we associate trauma and the propensity to develop intimal hyperplasia is through damage to the vasa vasora, and so these avoid that. It also avoids the vessel manipulation that is oftentimes associated with juxta-anastomotic stenosis, which Dr. Roy Chowdhury showed a photo of. And it also creates a side-to-side anastomosis as opposed to an end-to-side anastomosis. And I'll tell you why that's useful. So this is the ellipsis device. And what you'll see from the top left is that there's a catheter that gets inserted either via the median cubital vein, which comes off of the side of the arm, or the median basilic. You then enter in through the perforator vein and go into the proximal radial artery. There's a fusion that then occurs, and the anastomosis is up in the right-hand side. You can see that there's flow going through the proximal radial artery through the perforator vein, and then eventually on the lower side, you see blood flow that goes through both the superficial veins to the cephalic and the basilic veins. And so those are the target vessels that we are then able to cannulate during dialysis. So who is the ideal patient for an endovascular fistula? Those individuals who are anticipated to live greater than 1 year, those who are not a surgical candidate for a distal radial artery fistula, because we want to preserve the distal vasculature and preserve the venous real estate in the upper arm as long as we possibly can. There are patients that want to avoid an open surgery. Those individuals that are candidates who don't have any evidence of infection. They meet the vascular parameters that are stated for each of the devices. And then those patients that actually have a sufficient infrastructure for any additional procedures that may be required. A key contraindication really is lack of surgical support because some of the times these fistulas need to be transposed or modified in order to be able to cannulate them adequately. So how are these stuck? We typically have a pump speed around 350 to 400, which in most cases outside of maybe the South where I used to live, where people were cranking up to 450 and 500. They're more on par with a standard pump speed of around 400. The puncture location and cannulation technique really depends on where the greatest amount of flow is going. And so these are typically dual channel outflow, which means that they're soft, they're squishy, and they're low pressure as opposed to having a higher pressure surgical fistula. But the interesting bit of this is that there's generally no scar, so they're not easy to identify unless you know what you're looking for. So there have been times at which we've had patients that are going into the emergency room and somebody thinks that they just have a nice juicy vein in their antecubital space when in fact that's their endovascular fistula. So we're really now taking care to try and flag that in the EMR to ensure that people aren't inadvertently sticking a fistula when they think it's a vein. So this dual channel outflow is important. And this is what it looks like. And I have several patients that I've created these in. The person in the lower right is my patient. You can see there that there's a needle in the basilic vein and then one in the cephalic vein. And the beauty here, again, is that cosmetically these are really desirable over that of a surgical fistula, which over time oftentimes tends to get dilated and large. So some critical elements that need to be in play is a multidisciplinary team. So obviously your patient needs to be on board, and oftentimes once you present, at least my strategy is I present surgical fistula versus endovascular fistula, and we have a discussion about how best to approach it, and then the patient makes the final decision. You need the nephrologist to be on board because they have to weigh into the pump speed and the dialysis prescription and to ensure that the patient's actually going to get sufficient dialysis. And then obviously the dialysis unit staff, because that's where all of these will be based. The survival of this technology is based on what happens in the dialysis unit and the ability to cannulate them. And then obviously the interventionalists and the surgeon need to be on board. So what else is required? Aside from the candidate selection and pre-procedural planning, there needs to be a plan for post-procedure follow-up. Any ancillary procedures such as transposition, bringing them closer to the surface, or shifting flow because it inadvertently went in a direction that you didn't intend it to. We need collaboration with the dialysis units and then education of the nephrologists. So how do these perform? There's excellent 2-year data from the Ellipsis data, and I present this because the other device does not have 2-year data. They don't have anything beyond 6 months. They're working towards that in their post-market study right now. But you can see that at 24 months, the cumulative patency of this device is actually very good. It's 92% of patients continue to have a patent AV fistula after 2 years. And equally as important is the patient satisfaction that's associated with this device. The majority of patients actually find this very favorable with regard to the level of pain experienced during the procedure, the perception of technical ease in performing the procedure, and the satisfaction. And the satisfaction in the comparison to the previous procedure took a little bit of a dip because of some of the challenges around cannulating and ensuring that there's sufficient education in the dialysis units around sticking a softer, less obvious and high-pressure fistula. So what we don't know about these is long-term patency and complications, which are in the process of being studied currently, whether the dialysis units can really successfully cannulate them, whether they meet a typical dialysis procedure prescription, and then what percentage of patients are actually true candidates. This is a kind of a graphic of where those fall in terms of the decision-making around the new KDOQI guidelines in terms of individualizing patient AV access. And you can see that they fall in the forearm, so ideally we want to start off in zone 1 for a distal fistula, and as we move up the arm, the endovascular fistulas become more appropriate. Okay, so I'm going to touch upon a couple of other things because I realize I'm a little short on time here. I don't want to run into our next speaker. The radar surgical technique, which our surgical colleague may potentially touch upon, is a nicely studied technique that's done for radial cephalic fistula that actually has resulted in better juxta-anastomotic patency compared to a standard surgical fistula. And the difference that you conduct in this particular technique is that the artery is actually swung over to meet the vein as opposed to the vein being swung over to meet the artery. And in fact, that has actually resulted in improved maturation and patency for distal AV access. Nice paper that shows that, and fewer secondary procedures. The Wasse device, which Dr. Roy Chowdhury touched upon, is an external strut, effectively, that reinforces the vein and comes up with the ideal configuration for fistula creation, and it can be employed in any one of the fistula from the distal arm to the upper arm. It's a tapered transition, and it allows for an improved flow profile to modulate shear stress and to optimize the configuration. And this has actually resulted in a very beneficial improvement in terms of vascular access patency and can be employed at both the lower arm, as you can see there, as well as any configuration at the brachiocephalic or the brachiobasilic vein. There's also a device that many of us find quite interesting, which is called the Amplify vein dilation system, which is being evaluated currently. And the whole intent here is to precondition the vessel that is going to be used for vascular access. In my opinion, this is a little bit of an invasive attempt to do that. It requires a port and a long catheter to effectively allow for more rapid blood flow through the intended target vessel. But the originators of this state that there can be huge benefits in terms of potential patency down the road for these patients. So quickly, in terms of AV access dysfunction, there is a device that's called the Alio, which is actually, I think, pretty neat, that is a strip that looks like kind of a nice Band-Aid that can lay over the vascular access. And it's a plug-and-play, so it can transmit volume flows for vascular access surveillance that can be followed over time for patients. And they also have added in clinical metrics with the potential to evaluate patients' blood sugar, potassium, and other electrolytes that can allow the nephrologist to get a little bit of an early warning sign whether or not there are any issues that need to be addressed in the patient. And then finally, drug-coated balloons. which I'll quickly go through. These drug-coated balloons you've heard of for stents and things in the coronary arteries, but for dialysis vascular access, they've been moderately late coming, and some of the previous attempts at employing the use of these have not been shown to be beneficial until this most recent study, which utilizes paclitaxel, which is a microtubule inhibitor, and there's a paclitaxel-eluting balloon. And the first study was called the Lutonix study, which did not show any patency improvement compared to plain old balloon angioplasty, non-inferior. However, the next study, which employed the use of a slightly higher dose of paclitaxel, did in fact show post-intervention primary patency improvements over that of a plain balloon angioplasty. And this is how the drug-coated balloon works. You inflate it for a 2-minute period. The principle is that the paclitaxel actually seeps into the adventitia and prevents ingrowth of intimal cells and mitigates the ingrowth of intimal hyperplasia. So 6-month data that initially was posted came out and showed that 82% of individuals treated with the paclitaxel balloon in the IMPACT study had remained intervention-free compared to about 60% of those with a plain old balloon angioplasty. This study was then followed through to 24 months, again showing an improvement in the blue of the IMPACT balloon paclitaxel study. 52% of patients had maintained primary patency compared to balloon angioplasty. And then they recently came out with their 36-month data, which again showed a significant improvement and a 21% reduction in reinterventions with use of this balloon. So we use this a lot at my institution when we don't want to stent recurrent lesions that are stenosis, stenotic, and balloon angioplasty. That's a standard, is not actually tremendously efficacious. So this is a balloon that we pull out and use from time to time. And then quickly, treatment of central stenosis, which oftentimes results from protracted central catheter use or pacemakers or CIEDs, which can limit vascular access placement in the given arm. There's now a new device that allows for relatively rapid recanalization of the central veins called the Surfacer device, which is actually really neat. And it looks like this, where you go through the femoral vein, and there's a straight path up the iliac vein all the way through the inferior vena cava, and then it allows you to pop up right up above the clavicle to the internal jugular vein and place a central venous catheter. So once that's in, one is then able to put in a hero graft and switch any lower extremity access, which is at greater risk of infection, to one of an upper extremity access. So this has been a very helpful tool in terms of rapid recanalization for our patients with central occlusion. So I'm going to end there because I don't want to run into my next speaker's time. I thank you for your attention. I point out that this fountain may be flowing today. I don't know, but it's worth walking around the campus and seeing it because it's absolutely beautiful. Thank you. I don't know if you have any questions or not.
Okay. Thank you very much, Dr. Wasse. We do have time for a question or two. Scott, are you up there to ask? You're up the next speaker. Yeah. As far as I know what that is.
He's over here.
Oh, okay. Sorry. Thank you, Doctor. I guess what I wanted to ask is on the ellipsis. My name is Eric Ditchman. I'm a 21-year home dialysis veteran, but mostly with home hemo. You mentioned the nurses. You mentioned the techs because and you mentioned how squishy it is. I didn't hear you mention patients because what I think is we have these new devices, and I would have really appreciated this surgical intervention didn't work, right? And had we talked about the ellipsis, in 2001, maybe that would have been a better option, than going here. I'm actually now on my third graft. So first of all, was the fact that you didn't talk about patients cannulating themselves, which is very important for independence, whether we do it in center or if we do it at home. But the other aspect of that is also being able to retain the use of our dominant hand. So as we build these, and we need to be able to use this, and we need to go back and keep going back as opposed to here, here, here. It just makes it much more difficult for us to stay home and to be independent while we do it. Thank you.
Yeah, no, thank you so much for mentioning that. So I didn't touch upon self-cannulation with either of these devices because to date nothing has been published about that. So I'm generally relatively cautious about mentioning things, but I will tell you anecdotally that for those individuals that use a lot of these, so I have colleagues in Texas, for example, in Houston, that have created over 100 of these endovascular fistulas, and at least 50% of those creations are done for home hemodialysis patients who actually use buttonhole cannulation oftentimes for these types of fistulas. And the main reason is because they're located right at the crease of the elbow, and sometimes one of the vessels is somewhat deep. There's a limitation in terms of the ability to use rope ladder cannulation. And so buttonhole is employed in a very successful way, and that's something that's emphasized with these. But to date, there just hasn't been anything published simply because they've only been FDA approved for about 2.5 years.
That's excellent. Thank you.
Yeah, you're welcome.
One more question here.
Actually, I can yield to anyone else because Eric just basically asked the same question I was going to. So I got my answer.
Well, stay tuned about more patient-related data with these devices because obviously it's a big emphasis for those of us that are creating these, and I appreciate your question about that. Thank you.
Okay. Let's thank Dr. Wasse again, and